No.
So I'd like, on behalf of the River Strand Fitness, Health, and Wellness, is that the right name? Fitness, Health, and Wellness Committee to welcome you all and to welcome Glenn Orser, who's going to talk to us about ergonomics, what it means, what we can do about it. I'd also like to mention the upcoming fitness committee.
We have future guest lectures. My name is Julie Fisher. I'm the chairperson for Fitness, Health, and Wellness. We have got a lot of upcoming guest lectures coming up for the month of March. So for March the 12th, we have a Zoom meeting from a company called the Elevated Plate. It's going to be healthy eating and strategies for incorporating the Mediterranean diet into your daily eating habits. That will be on Zoom, and so that will be at 12 noon. Then also on the 19th at 11 o'clock in the morning, we have a physical therapist who's going to come in and talk about movement as it relates to pickleball and golf. He is Titleist certified, and so he is really going to be able to help people who might be having some injuries as it relates to golf or an existing injury that might be exacerbated by pickleball or golf. And then also on the 26th, we're super excited about that. We have a 4-physician panel. This will be taking place in the clubhouse in the evening, which is a little different. That'll be at 5 p.m. to 6:30 p.m. We have 2 doctors from from 360 Orthopedics and 2 doctors from Reed Medical, and they'll be talking about the subject of, is it just an ache and pain, or is it something that you should pursue? There'll be light bites that will be provided, so that should entice people to come. And we're really excited to have that. And throughout the summer and the months that we are going to be closed here in the clubhouse, our committee is still going to be offering guest lectures at least twice a month throughout those months. So keep an eye on the newsletter. Make sure you look at your Sunday, Wednesday e-blasts, and also on Club Street. Thank you.
Also, we hope to have in maybe April, a community-wide scavenger hunt, exercise-driven scavenger hunt.
Yes.
So with no further ado,
Excited about that.
I welcome you to listen to Glenn Orser.
Thank you. I am Glenn Orser. My wife is Jan, officially Janet. She plays 9 holes golf, does Pilates regularly. I've been doing ergonomics for a long time. I've been in the wellness and health avenue for well over 50 years. I graduated as a phys ed major. My master's project was in community health. I ran a bunch of health clubs for a while. And then I was asked to be a director of a physical therapy clinic that was kind of unique. We only dealt with failed surgery cases, and we had 17 therapists that worked in our PT program to make people better. And as a result of my working there for 6 years, I've gained quite a bit of knowledge. And working with chronic pain patients is, in and of itself, an eye-opener. So that's me. I have traveled over half the United States and several countries doing what I do. I've never advertised. It's just that this class is so logical. The common response is best class I've ever had. Why didn't we do this 20, 30 years ago? Why didn't we know this 20, 30 years ago? And in my years of doing health, it is your responsibility to understand what's going on in your body when you have some issues happening. That's your responsibility. We should not be relying on our doctor to do everything. It's your responsibility to at least gain some understanding so that as you go through your process, you can become a better reporter to your physician, because most of us don't understand health. And we're really lousy at reporting our aches and pains, or whatever the issues may be. And so this class is aimed at giving you some wisdom, but understanding is you using that wisdom. So this is typically a 4-hour class. In industry, it may be 1 hour a quarter in a year, or it may be 4 hours all at once, or two-hour classes, but it's a 4-hour class, at least in terms of my material. I know most of you don't want to sit here for 4 hours, so I've cut everything in half, and we'll try to cover everything in this 2-hour time frame. As always, your doctor drives your good health legally, and so legally I'm telling you, see your physician and don't count on just taking over and doing what I say for granted. So ergonomics is a science that's been around since the 50s. It became heavy when the pilots could not control their airplanes because they got too complicated. And the human and operating the control panels and so forth became a problem. And so we had some people that came in to look and simplify and modify so that when I look at panel of instrumentation, if they're all good, they're all facing in the same direction, as opposed to an arrow here, an arrow here, an arrow here. So a lot of ergonomics started with the aviation industry. But simply put, ergonomics is simply saying, from a work perspective, who do I hire? And what do I tell them about work? What is my work going to be? How do we define that work? That's some of ergonomics. And what we're trying to do is to make you, as an industrial worker, no matter what your job is, capable of performing your job tasks for 30 or 35 or 40 or whatever the route is. Can I do my activities? Can I play tennis for 45 years and not expect to have an injury? For most of us, the answer is no, and I played tennis for 30 years. I came down with a little rotator cuff for a moment in that process. And for those of us pickleball players, how do I not hurt myself the first day I'm playing pickleball? Or within the first 6 weeks of playing pickleball. So it does become difficult in pickleball playing to know how to weave through that and make sure you don't get hurt in the process. Matching work to who you are. Now, are we all the same? From an ergonomic perspective, everything you buy nowadays is designed on 90% of human beings. That 90% is above the 5th percentile female in terms of medical data, and below a 6'2" male. So if you're shorter than 5 foot and taller than 6'2", a lot of the stuff on the market doesn't fit you. What do we do about that? Well, we've gotten better at the make small chairs for those of you who are 5 foot, 5'2" and under, and then make big chairs for people who are taller. And do we sit a lot? In some jobs? Yes, they do. And so there's that kind of equipment out there. So we've gotten better over the last 40 or 50 years of ergonomics. So we look at the anatomy, the physiology, and the psychology of it. The good news is Jan's a psychologist, and if we had some of those issues, I would consult her, and we did some of those things. And you compare that to the tools, equipment, and methods in which you work. Now, this same process applies to what you do at home. If I did this for a long time, and then I go home and I knit and I crochet and I'm doing hobbies all the time and I'm nonstop using these hands, are your hands eventually going to get weak? Don't we all get weaker as we age?
Well, they might get
Is there anybody stronger now than when you were younger? You think so, Michelle? That would be a nice thing to think about. And we ought to pick up on some of your habits. Did you make new habits?
Absolutely.
Excellent, thank you. So matching work to who you are. And it's a simple process. This business of ergonomics is relatively simple. That's why as a phys ed major, I could pick this up fairly easily. I had a subspecialty in biomechanics, and that lended to some of my credibility. I also purchased, at the time, a $38,000 software package that took a program that the University of Michigan at their Center for Ergonomics developed, and I'm able to analyze you doing something on videotape, and every frame, whether it's a 30 frame or 60 frame camera, gets analyzed by the software package and gives me data about who has the strength to perform these tasks. So there's some very sophisticated programs out there, but even what they do is simple to understand and apply to work or play or home chore environments. There are only 6 hazards in ergonomics, just 6, and you're looking at them. Force, repetition, environment, duration, vibration, and postures, and I've listed the primary postures that I deal with. So these 6, say that again?
We all went like this, put our shoulders back.
Yeah.
Yeah, posture. You know, what do we look like? And I'm getting there, I'm in my 70s, more and more I'm doing this. My shoulders are here, my head is here, and my wife says, stand up. You know? I've got some issues where when my head goes forward, it opens up the foramen, opens up the facet, and I don't have as much ache and pain there. So it becomes a little habit of mine to go to that spot rather than do something that will fix it more permanently. Now, what these things do is cause fatigue. The heavier it is, the more you do it, the longer you do it for, the poorer posture you're in, you will develop an ache and pain. It's gonna happen in your body. These simply cause fatigue, and fatigue is the major cause for most all work injuries. How do I know that? Because you don't know what happened. It just was an onset. It just started. I've been doing this work for 30 years, and all of a sudden, how much less strength do you have as a 60 and 70-year-old than you did when you were younger? So can you see where this comes in the picture, where the majority of ergonomic injuries are showing up in the 40 to 50 age groups? In the work environments, certainly. But even when you were 40 or 50, you were still fairly close to what you were when you were 20 or 30. You were fairly close, it wasn't that bad. But then when we turned 60 and 70, in college, I could squeeze 172 pounds on my hand grip 9 down there. I can barely hit 110 pounds on this thing. I've lost 62 pounds of strength just in my grip. So if I'm working in a factory and I'm moving a lot of boxes, I'm going to be prone to elbow tendonitis. I'm going to be prone to trigger finger, tenosynovitis. It just makes me prone because I'm not as strong as I used to be. Doesn't that make sense? So if I've got a job, and I've got a job that requires me to work up here, what's my responsibility?
Get on a stool, be higher.
I can stand on something to lower,
Good posture.
Good job.
make sure I'm using good postures, make sure I'm getting enough rest and recovery. And rest and recovery has a its own marker in terms of ergonomics when we look at people working on the job. These simply cause fatigue. Fatigue is the beginning of the injury cycle. Fatigue triggers an arachidonic inflammatory response. Now, 40 years ago, I didn't even know what arachidonic meant.
I don't know what it is.
Do we have any medical people in here? Jason, are you familiar with arachidonic response? It's complicated, but again, it's fairly simple to understand. The daily general inflammatory response is to fight infections, bacteria and viral infections. Our body's capable of doing that, and that response will handle it for the most part, but not always. The respiratory thing coming around, I caught it about, it's now 6 weeks, and my lungs are still spitting up phlegm. They're still doing it. Now, I didn't want to go get a bacteria because my symptoms are fairly negligible, and we now know that most antibacterial stuff will ruin your gut biome. So I didn't want to do that to my gut biome. We learn these things as we go on. But a prolonged, targeted inflammatory response causes pain, tingle, burn, itch, and numbness. Those are the 5 major symptoms that people show up with from the nervous system. These are all coming from the nervous system. And we're all uniquely chemically put together. How many couldn't eat something when they were younger and you can eat it now? As a matter of fact, you like it. Or how many people found I was not allergic to something and now I'm allergic to something? Or I used to be allergic to and now I'm no longer allergic to. Our chemical makeup, there's a lot of chemistry going on inside this body. That's why food should be thought of as fuel, as opposed to something that makes me feel good, which I love desserts. I don't look like I love desserts, but I love desserts. Moderation, right? A prolonged inflammatory response contributes to arthritis. Arthritis is when we know it's happening at a joint, when you have some bone growth happening at a joint. And bone spur is when it's not at a joint. You've got a bone spur growing someplace, but it's not at a joint. That's the difference between arthritis and bony spurs. And lastly, scar tissue formation. A lot of times when they do surgery, the surgeon will look for fatty cells and bring them into this area so that things really are slippery and you don't irritate any more than the tissue has been irritated, and that may prevent some scar tissue formation. Is anybody in here scar heavily? You know you scar heavily? Okay. It's a problem. It really, and it causes all kinds of complications for you. It's just her duty to do something about that, to minimize the length of time my body stays in the arachidonic inflammatory response. And yet, that goes against our thought process, particularly us men, because we're stupid and women are smart. In general, I think your wives would all agree with you. I think these guys are not looking good. Anyhow, I lost my thought. I am in myself. Scar tissue formation. Oh, heavy scarring.
Typical man.
Someplace with it. I was going someplace with it. It was a good point. Fatigue has no need for an inflammatory response. But the brain or your signals of pain, tingle, burning, itch are telling the brain, you've got a problem here. As long as you've got a problem someplace going on, this arachidonic response is just going to keep coming and keep coming and keep coming. Okay. How long should we let it go for? What's the smart thing? Short time. What's not smart thing? Unwise thing?
Ignore it.
I can't tell you how many rotator cuff men said, yeah, I waited about a year and a half before I saw my doctor. Have some of you done?
I waited 8 years and my shoulder, now I have retracted everything, it was torn. And so the options are increased physical therapy or a shoulder replacement. So, cause it was all from work-related injury,
Mhm.
you know, and, so, I just didn't address it. It kept getting worse. Finally, I said, well, I've got good insurance now, I'm gonna.
Yeah, exactly.
Well,
Insurance.
that's the problem.
Or when we were very young and we had a significant injury, I can't afford
Right,
Yeah.
it's a lot of it's
to
affordability.
do things, yeah. So, all pain relief medicine's purpose is to stop this pathway. Whether it's medicines that are gonna work to shut down your nervous system like Tylenol, or whether they're anti-inflammatory aimed at stopping this response. Those are the only two meds that are out there. It's either gonna be working on stopping your nervous system from alarming, from pain, tingle, burn, itch, and numb, alarming and making your brain say, yeah, let's do this inflammatory response going on. Or aspirin, ibuprofen, or naproxen sodium. Which stops this process. This is the arachidonic pathway. It's complicated. This was not being taught even 20 years ago. COX-1, COX-2, COX-3 inhibitors. For some of you who have been chronic says I've had pain for longer than 6 months. For those of you who have been chronic, you might have heard those terminologies because they'll come up. Cooxygenase is an enzyme that's required to help produce white blood cells. They help with the production of prostaglandins, which help make white blood cells. And they inhibit processes to stop this cascade of inflammatory response happening in your body. Aspirin is now found to be a COX-1 and a COX-2, and the same for the ibuprofen and Aleve, and some more of the prescription drugs are COX-1, COX-2, and COX-3. The trouble with prescription is the side effects are much more likely to happen in your body with long use than lesser side effects. Does that make sense? So we try to avoid the prescription med. And that becomes difficult because sometimes prescription is just more of the same medicine. But more of the same medicine just hastens, if you're disposed to getting some of these side effects, it's going to hasten that because you're putting more medicine in your body at once. Does that make sense?
I'm going to take an issue with that a little bit.
Go ahead.
From the medical standpoint. I agree with you, absolutely. Some, for example, the prescription strength ibuprofen is 800 milligrams, is 4 of the over the counter. Works better, has more GI upset and some other possibilities.
Correct.
However, the COX-2 inhibitors
Do not.
are
They
more
reduce by 32% the likelihood of you getting an ulcer.
right, but they also kill the liver, which is why some of them were taken off the market.
Yeah.
So, but there is a place for prescription medications. I wouldn't run to that.
Yeah.
You know, you hurt your ankle.
As long as Jason's talking about it now, let me say my piece. I'm suggesting 1 or 2 days of symptom is long enough for you to make a decision. Do I take or do I not take? If you take, I'll almost guarantee your symptom will start in a day or 2 if it's minor symptom. If the symptom keeps persisting even when you're on medicine, stop taking what you're doing, go see your doctor. Do that early. That's the whole name of the game. If we can get employees working in a factory where it's a heavy work that they're doing to think that way, there's a lot of dollars to be saved and a lot of ache and pain down the road that won't be harming them as they age up. So the thoughts are simple, and I appreciate that, Jason, I really do. Take early because you understand what's happening, and then you can respond to that within a day or two. Do I see my doctor? Do I need to do it? And even most insurance companies have an 800 number that you can call to talk about your issue, and they can help you decide, should I see a doctor or not see a doctor? And they're not used heavily because a lot of people don't know that your insurance carries that 800 number out there. You'll talk to a nurse, and then the nurse will put you over to a doctor if you have to.
And you do such a great job. I don't want to step on your feet here, but some orthopedists say that as soon as you turn your ankle, the injury is done. It's predicted how long this is going to last or how minimal it's going to last. But what also happens, as you were saying, Glenn, is that you release a cascade of injury, including prostaglandins and arachidonic acid. And the sooner you prevent that, the less inflammation you have in the long run.
Yeah.
So taking something early on helps prevent the continued swelling. You know, it's like get a bug bite. If you ice the bug bite or if you take an antihistamine, you may prevent the swelling that causes you more problem later.
Yeah.
I have a question.
Right.
With that in mind, a lot of people take the ibuprofen because it handles the inflammation. But I have marginal kidney issues, and they tell me never to take that, just take the Tylenol. Well, the Tylenol blocks the pain, but doesn't do anything to the inflammation. But if you have an injury, do you take the ibuprofen for a short period, 1 day, 2 days, 3 days, or you just take the Tylenol? And I mean marginal
Yeah,
kidney.
the
not bad.
Tylenol can block the inflammatory response as well.
Oh, I know,
Yeah,
it blocks
can.
it, but it doesn't do anything with inflammation.
Yeah, there's still inflammation there.
But my point is the ibuprofen takes care of the inflammation.
Well, it prevents it from happening. That's the difference between the two.
Well, if I have a sore shoulder because I swim every day and golf every day, and I take the Tylenol, it blocks the pain.
Yeah.
But if I take the ibuprofen, it'll decrease the inflammation and block the pain.
A lot of things are dose related and time related. A
I'm
small
talking minimal dose.
Yeah.
a small dose for a short period of time is probably not going to cause problems, but you should speak to your doctor about the advisability
I've
of that.
already, the doctor said, I've been playing basketball until I was 58 years old. I took 800 milligrams of ibuprofen, and they said, don't do that, you know. So I don't take ibuprofen at all.
Yeah.
But my point is, like, I've got a slightly sore shoulder from swimming and golf. Well, do I take Tylenol? Do I take ibuprofen for 2 days? You know what I mean?
Well, he just told you don't take 800 milligrams. Ask him if he can
I
take.
would take
Yeah.
200 or 400.
My suggestion to you is.
I don't mean to interrupt.
No, not at all. It's a great question. I love the questions. My answer to you is, if it's happening on a regular basis, you're doing the same swim routine, you're playing the same amount of basketball.
No, I don't do basketball all the time. I'm 71. I'm not bad.
Okay. All right, so if the swimming is do it before you start to swim. Take it a half hour before you start to swim.
I usually
Take a half a dose.
take afterwards. I stretch well. It's not anything that's even
Okay.
on a pain level. It's a 2 or 3. You know what I'm saying? But I notice it.
But if the swim is a half hour,
45 minutes. Yeah.
okay, if the swim's, you're 20 minutes into it, you're hitting the fatigue cycle already because you're 71, and the gym is not doing anything to improve your shoulder strength.
It's actually the other way around. It's sore when I start, and when I swim, it's sore initially, but then it loosens up,
It
and
abates.
I do okay.
Yeah, it
Then
abates.
an hour afterwards, like right now, I want to keep stretching. You know what I'm saying?
Yeah.
And it feels good to stretch.
Yeah.
But I guess my initial point, and I don't mean to take the time up here. If you take Tylenol, and I take it a little bit every day, just as an anti-pain, but it doesn't help with inflammation. My thought is if you took some ibuprofen, the inflammation would decrease, then ultimately there'd be less pain. Is that logical or no logical there?
It's logical, but like you said, everything's a risk benefit.
Okay,
Yeah.
short term.
Yeah.
Got it, okay.
And your doctors are constantly doing that risk benefit statement. They're constantly doing that.
What do you believe in electrolytes and a lot of water and being inactive?
Yeah. You use up a lot of enzymes, electrolytes, and so forth when you're doing work. So if you're golfing, if you're playing tennis and it's 2 hours of tennis, you need to replenish that. You do. It helps the body function. Water more and more is an interesting topic. You know, old experiment says water, you talk to water, you freeze and it turns into chaotic crystals. You talk to, this is talking to a water bottle, a Japanese study by a college. You talk to water with words of love and encouragement, you get beauty and harmonious crystals formed. There's a group right now showing pictures to water. They freeze the crystals, they form the picture. We're 72% water. They're saying water has memory. And this picture thing is demonstrating that.
Is there a difference between cold water and hot water?
Yes, there is.
Okay. Sorry, I didn't mean to interrupt.
Yeah, it doesn't go into the detail, but I'm not gonna take time. I gotta bypass this. Well, let me just tell you, this is a cookie company, and they're making the icing that goes between the sandwich. And this company has been out there for 34 years. The first 3 guys they hired are operating 3 of these machines right here. And they load 1,000 pounds of product up here, it gets mixed by it. They pull on the handle here, and it rotates down, and some of it falls in, but then they take the shovel and they pull it in, and they push this into the company, the main production floor, where the sandwich is going by, and the funnel icing goes in, and it puts the on the cookie, and then in the process, right? So here's 1,000 pounds going in. Oh, those blue things are 50 pounds of lard. 180 pounds of sugar going in. That's basically icing. Anyhow, it's 1,000 pounds going in. They push this, it's on wheels, they push it in the factory setting, and then it gets lifted, or they hand shovel to shovel it into the hoppers in the factory. So 2 of the workers, one went out with back injury, the next one went out 6 weeks. They were all hired at the exact same time, and the other one went out about 3 or 4 weeks later. All 3 of them went out. It cost, for the first 2, it cost the company $380,000 just for the first 2 injuries. The third guy was a little bit younger, his injuries weren't so bad. But I commonly hear this. This is the common thing. Now, why did they fatigue?
Bend over
And they make a batch an hour, that's 8,000 pounds a day that they're lifting into the machine. And they do mechanically lift it and throw it into the machine. Anyhow, no brainer in terms of how to make this better and simpler.
Oh, you don't know
We did a short term. At each station, we put some lifts up and lifted that container up, lowered one end, put an open door on it, it slid right into the hopper. Stopped all the shoveling that was
That's
happening.
why they have robots.
Yeah. They can deliver the products a different way. There's all kinds of things they can do that cost money. All right, so I'm going to go through this and give you a quick review of tendinitis. Tell me what a tendon does.
Muscles to the bone.
Attaches muscle to bone. Every muscle has a tendon at each end. The big muscle here and the tendon, you can feel the tendon there. It's that fairly big structure right there, and that tendon attaches to the bone. So the attachment to the bone positions the muscle. Does the same thing up here. I have 2 tendons coming off the bicep, up in the shoulder area, one to one place and one to another place, to position my bicep muscle. Every muscle has 2 tendons. So why do we get so much tendinitis? What's unique about a tendon that it would cause the tendon to fatigue faster than the muscle?
The blood flow.
It's got very poor blood flow, which is why in anatomy pictures, you'll always see muscles painted red and tendons white. Or any structure that's painted white, you notice all bones are painted white. Except when you do the cross section, in the middle of that bone, what color is it painted? Red, because that's where your red blood cells are being made. So they have very poor blood supply and they're mechanically strong, mechanically weak, much weaker than muscle is. Mechanically small. And because they're mechanically small, you've got a greater percentage of stress at the tendon level. Sometimes we'll tear a muscle, sometimes we'll tear a tendon, but you'll have more tendon tears than you do muscle tears out there in most work environments. Depending on the injury of the tendon. What does itis mean? Inflammation. So name me some common itises. Bursitis, arthritis, pancreatitis, the list goes on and on and on. Every single one of them simply means you have an inflammatory response hanging out at that tendon level. Now, if I have a torn muscle, or if I have a torn ligament, or if I have a torn tendon, muscles can repair in 4 weeks. Tendons maybe 6 weeks, and maybe 8 to 12 weeks for a ligament to heal up. So how long do you want that orthodontic pathway to be there? Give it enough time for it to repair and improve its function again. And that's what Jason was alluding to a little bit earlier. If I sprain my ankle, has everybody sprained their ankle badly and it looked like the size of a softball? You know, for 6 weeks it looks like the size of a softball, and then the doctor may put you on a prescription med, or he put you on it initially to minimize that response, that inflammatory response from happening in the first place. All to help with your recovery. So when we do have trauma, you need that response. You need that pathway to work in your body, to heal your body. Prolonged inflammation. Prolonged inflammation is more and more they're saying that the white blood cells in your body, the macrophages, the nastier of the inflammatory responses are hanging out there, and more they're saying that they're probably not healthy for your tissue for macrophages to be hanging out there. Does that make sense? Macrophages are the eaters. You know, they'll eat, they'll engulf is the term that's used. They engulf bacteria and virus and kill it. Trigger finger tenosynovitis, every tendon has a coat around it. If that coat becomes inflamed, the tendon can't clot. And sometimes you get a popping sound of a trigger that's stuck on you, will pop open. It's a little, the coat, the sheath is inflamed, and the tendon won't glide through it. That's relatively simple. Taking stuff early. Buddy.
Oh, sorry about that.
You're good. Tennis elbow is the outside elbow, golf elbow is the inside elbow. Waitresses get golf elbow because this will impact on the inside elbow. This will impact on the outside elbow. If you, the tendons here, this common tendonitis issue, is a really small tendon, and the fingers attached to them are pretty big muscles. So I got a small tendon there. If you put your hand on that tendon and you flex, you'll feel the tendon almost elongate. And the longer the position that both the muscle and tendon are in, the less strength the muscle can generate. So it increases your risk for fatigue. So if I got a job, my job is to do this for 4 or 5 seconds and 300 or 400 times a day, I'm going to be predisposed to having tennis elbow. I hit that tennis ball, if I'm not a good player and I'm hitting all around that racket, not the sweet spot very often, wobble, 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 that's a lot of force for those little small tendons, and it can cause tennis elbow. This is going to be tennis elbow, and this is going to be golf elbow. If I take a big divot, you tend to hit the dirt. You're in the opposite. This tendon is now elongated. These muscles are now elongated, and you tend to get some tendonitis here. Epicondylitis is its medical term. So ibuprofen, naproxen sodium, which is Aleve, Motrin, and Advil are both ibuprofen. These are the non-steroid anti-inflammatory medicines. Talk about the COX-1, COX-2 inhibitor, and the ulcer is 32% reduced with Celebrex, because it is a COX-2 inhibitor. And that COX-1, COX-2 just simply says, in stopping that cascade of inflammation, there's a number of paths that we can do it. This path does not affect your stomach, and that's why it's prescription Celebrex. Okay. Acetaminophen is Tylenol. It's not an anti-inflammatory. It's a medicine that works on your nervous system. When you go to the dentist, what do they give you? A medicine that works on stopping your nerve from functioning. Right? So what's steroids? What's cortisone? It's a superior anti-inflammatory. It blocks that cascade, but it does it to prevent that pathway. It works very well, but what are the side effects? Much greater, much sooner in the body. So you avoid it, but if the doc says you need it, unless you have a good rationale for saying, no, I don't think I want that, go ahead and have it done. There are certain injection points that they'll do, like if he's certain it's bursitis in the shoulder, they'll probably inject it. It's one of the very largest bursa in your body, and if he thinks it's bursitis, you need to stop that cascade. You need to stop it in order for the bursa to do what it's supposed to do. Sometimes the hip joint will do that right away. The heel joint's a commonplace. So again, the bursa, bursa, and bursa, all three are bursa. When the bursa becomes irritated, it tends not to make the oil that it's supposed to lubricate that area. So you stop that cascade and you don't irritate, and it continues to make the lubrication system that joint requires. So carpal tunnel is a fairly frequent injury even as you get older. My neighbor down the street from me just had carpal tunnel surgery at 76 years of age. He hasn't worked in a long time, but what has been happening to that grip? He's had numbness in it for a long time. I've had people tell me, I've had this now for 10 years. Have you done anything about it? Do you know what it is? No. It doesn't hinder me from doing anything. There's some pain, and sometimes I'll smash my arm into the wall. We do some stupid things. But if, you whack something and that hurt. What's this doing? Overstimulating your nervous system to stop it from triggering. That overstimulation will stop some of the nerve endings from sending the alarm to the brain. The purpose of understanding pain relief is to take medicines early to prevent that prolonged response. That's it in a nutshell. When I say early, 1 or 2 days. My subjective response from I've probably trained over 500,000 people in my life of doing what I've been doing. The common response is, I do what you say, and within a day or 2, it's gone, and it doesn't come back. 4. Some of them is 4. The time that it takes for it to come back is much longer than they used to when they didn't control it, when they didn't minimize it. I also have a general rule of thumb for my own. Every time I take more than 12 pills in a year, I tell my doctor to record them. I've taken 12, whatever, I take naproxen sodium because I respond very, very well to it. I can respond to a half a pill and get the same response as I do with 2 pills. And again, that's my chemistry. We all have our own chemistries. At our ages in this room, we should know by now what medicine I respond well to. You should know that. And I'm suggesting you respond very well to ibuprofen.
I do.
Yeah.
But I don't take it.
I get no response from ibuprofen. I get no response, but I get that with naproxen sodium. I just assume it's my chemistry.
Isn't that the same family though?
Close, but they're all uniquely different, which is why they receive their own unique little patent.
But would that also hurt the kidney function?
Yeah, they do.
Yeah.
But that's part of why I minimize, or when I take more than 12 in a year, I mark it down.
In a year?
Yeah, 12 in a year.
That's-
So you're way over that, aren't you?
I haven't taken any for 6 years, but that's neither here nor there.
Okay.
Like 12 in a year seems inconsequential to me. But I don't know.
I'm sorry, we're on carpal tunnel. So carpal tunnel is a nerve that goes down your arm, and it goes to all your thumb, all your pointer, all your middle, but only the inside portion of your ring. So when you go see the doc, the first thing I'll often do is tap. Do you feel this? No. Do you feel this? Yes. Now, it doesn't always show up in all 3.5 fingers. It will start in 1 or 2, and as the symptom is progressively worse, you'll get it in all 3.5 fingers. If it's the outside portion of your ring finger and your pinky, that would be the ulnar nerve. The ulnar nerve sits right in this groove here. And I sleep in positions where my pinkies, both right and left, are dead at least every other day. It's numb as could be. So I do this right now, and that shoots right down to my pinky finger. I'm in a hypersensitive sensitive mode for this problem. It has never turned into a problem for me, but that hypersensitivity, if I were doing something that were aggravating this, I would have medical surgery and they just move that nerve out of that groove and they put it here.
What's the difference between carpal tunnel and neuropathy in your hands and feet?
Carpal tunnel will just be 3.5 fingers.
Oh.
Most of the time with neuropathy, and the clue is if it's all 5 fingers, we got something going on up in the neck, or we got something going on in the elbow, because after that, they split. There's 3 of them that feed your hand. Three nerves.
Both hands?
If it's bilateral, it's gonna be neck. It's gonna
Well,
be something.
so neuropathy simply means a problem with the nerve.
Yeah.
And
You
it,
got symptom going down.
and so when it happens with no cause, we call that a peripheral neuropathy.
That's what I have.
But you can have a neuropathy from being impinged by your, by carpal tunnel.
Right.
Yeah. Yeah.
Okay.
If it's affecting the whole hand, and you need to know where to tap.
Probably just the ends of the fingers.
Okay. So tap the fingers next time. If it's the pinky and the ring and the other ones, there's something going on at higher levels. Because it's not likely that all 3 of them are getting impinged someplace in your arm to cause all 5 fingers to have symptom in them. Okay? So what's injured is the median nerve. And the median nerve is in the middle of the arm, except when it comes to the hand. At the hand, it becomes a surface nerve. It is directly underneath here, which is why when they do one of the studies on you, they just kind of tap. You feel that? You feel tap for about a minute. You feel that? Yeah, I do. That's a sign that it's carpal tunnel. There's a number of differential diagnoses where it appears to be carpal tunnel, but it could be something else, and they got to rule those things out. But the high probability, if 3.5 fingers are affected, you've got the median nerve being affected. The symptom often is worse during sleep. My wife Jan has to wear braces. She has been wearing them for 25 years now. She has to wear them because she is one of these sleepers. She grabs those covers, and I'll see her, she'll wake up and her hand is just like this. And if you do this for a long period of time, you're going to irritate your median nerve right in the carpal tunnel area. The 3 ergonomic hazards associated with it are force, repetition, and position, and 90% of the time it's simply posture. Your wrist is down here or it's up here. Deviated more than about 25 degrees down or 25 degrees up, you become significant weaker in those postures. Sweeter, ours came out. Okay. Take that. He hit 85 pounds. Take that. And point this at your heart. Go ahead. You're done.
Yeah.
He hit 40 pounds. That's a 50% strength of loss. So if you were doing a job task and you have a 50% strength loss, how soon do you fatigue? And if this is a somewhat repetitious task, how long will it take for you to fatigue? Eventually in your job, eventually you're going to have carpal tunnel out there. And the sign and symptom is kind of straightforward. You know you got carpal tunnel because it's affecting those 3.5 fingers. Go see the doctor early. I've had hundreds and hundreds of people tell me it's been greater than 3 or 4 or 5 or 6 years. I've been dealing with this problem. Hasn't been a dysfunction for me, so I haven't done anything about it. The surgery that they do works about 50% of the time because all they're doing is making a larger opening. They're just making a larger space so the inflammatory squeezing is less than. The hand docs often tell me that when they go in and look and they see it's a triangular shape. It's no longer round. There's such pressure in there that it gets squished because I had all the coats of the tendons. All these fingers have a tendon attached to them, and the coats inflame, one here, one here, one here, and they form a triangle in their shape, and they squeeze that thing, and it's bright red when they look at it, and all kinds of stuff. So we can splint, we can inject with steroids, and that's what they'll often do if you tell them 2 years and 3 years. You know, your prescription meds are not going to work very easily on you. You need to stop the inflammatory response. We want the wrist neutral and straight. Any symptom in the hand, because this is where I'm strongest. I want that there. In the game of tennis, in the game of pickleball. You'll see in pickleball, a lot of new players trying to put spin on the ball. You'll see the wrist move. That stuff doesn't work very well. You don't see that at the high level of play. And it'll probably cause some elbow issues and even though it's a wiffle ball, even though the force is minimum. Question on carpal tunnel? The common term for the shoulder injury is rotator cuff. You got a good 60–70% of the time if you got something that this bothers you, it hurts you, you probably have at least a 70-75% chance that you have the typical rotator cuff injury. Bob, stand up for me. Face that way. Yeah. So, you've got this arm here, and at the top of this arm, if there's a ball up here, ball and that upper bone. I've got one that comes over the top and attaches to the top of that bone. I've got one very big, strong one that attaches to the front. One in front, one on top, two in the rear. They surround that ball. Thank you. Have a seat. They surround that ball and help keep the ball in the socket. As we get older, the top guy and the two rear guys tend to get weak because we stop doing motions that use those muscles. We don't do a lot of those activities. We stopped swinging the baseball bat a long time ago. Now, the good news in golf, we do use those muscles to play the game. But for the most part, this is an activity where my hands are higher than, or my elbows have reached shoulder level or higher than my shoulder. And I'm mechanically weak in this position, so the fatigue will happen sooner, and they come down with rotator cuff. And all they do is they send them to physical therapy. Physical therapy will strengthen the two guys on the back and the guy on top, and within 3 or 4 weeks, you're back on the job. If you reported it early. How many of you reported early?
8 years later.
Julie, yeah. Has anybody had a rotator cuff issue? Okay, there's 6 or 7 hands. How long did I let it go? You know what I hear in the factory all the time? I got this other good arm still working. I'm rusting this arm over here. Well, you're not really. So commonly, this bone right here, it's called the acromion bone, comes off your shoulder blade back there, and it's a little arch bone over the ball of the socket up here. And when you get weakness of the two rear guys, and swimmers are predisposed to this because we don't use those two guys back there in the activity of swimming, unless you're a back shoulder. You're gonna come into play, right? They don't come into play, so they tend to get rotator cuff again going on. And back to the picture. I thought I was on that picture. Sorry. And buddy, I'll send this. You're gonna get all these sent to you. Yep. So here's the top tendon. There's that arch bone here, and the ball down here. That spur will begin to show in most x-rays in about 12 to 16 weeks of someone having that short period of a rotator cuff injury. It'll begin to show up that quickly. And that bone always, it's bone growth always goes downward into the space. And now every time, even this hurts way down here because you've lost the spacing that's in there. You filled it with bone, and is this bone smooth bone? No, it's pitted, irregularly shaped bones. One guy brought in his x-ray, it looked like he was growing a front tooth right off the tip of that bone. Anyhow, it becomes a dagger that begins to stab that supraspinatus tendon up there, and it will cut it. It will fray it. Just being impinged between the two bones will fray that bone, will fray that supraspinatus tendon. And it will get weaker and weaker, and every time I do an activity in work or some sort of activity where my elbow goes high, you've got problems.
So Glenn, what do they do with, if it's, that spur is caught before it tears it up?
Yeah.
What do they do? Like
They just go in and do a
set it up?
surgery and cut the spur out.
Which is easy.
And the good news is that just requires an x-ray. Very seeable on x-rays. So I've got 4 rotator cuff muscles. They keep the ball in the socket. When weak, the ball always moves up. When weak, the ball always begins to move up out of that joint. Because when the four muscles remain strong, it positions your bones. Remember I talked about positioning bones earlier? They position, and when they get weak, the ball begins to move up. If you catch this early, I will guarantee within 3 weeks of doing very simple exercises, not that one, this one, and this one. You're just dangling it over something and coming up 90 degrees, or you're lying on a hip, the weight is down here, and you're coming up 90 degrees. You do a 2-second count up and a 4-second count down. Within 3 weeks, your pain will be completely gone. You will have re-strengthened, but if you keep doing it, it won't come back. You just do this exercise once a week with a decent weight. As a female, maybe 5 pounds. It won't come back. So if you are one of those prolonged tennis players and you want to keep playing the game of tennis, how long have you been playing, Donnie?
Only since 2002. I had 6 kids, so I could never do it. So I didn't do it.
I knew you playing tennis back at, we grew up in the same town.
Oh. A little bit there.
A little bit there, but not like you play here, right?
I just played a little there. With 6 kids, you can't play a lot.
You can't play with 6 kids.
But I have a question, because a lot of
Yeah.
these things, you say you have to catch early.
Yep.
I had bursitis in the hip, and it took me 13 doctors and x-rays and Valium and exercise before the 13th doctor diagnosed.
Are all the doctors saying it's bursitis?
No, nobody could, because
Ah.
I was 29 years old.
Ah.
Bursitis is usually in the shoulder. It was very unusual. I
there's
was
a-
at
there's a-
Cornell at the time. They
there's a-
told me it was mentally in my head.
Oh, good.
And I went, my brother-in-law was a doctor. He said, I have the best orthopedic. And I said, I've been to orthopedic, I've been to that. Because I always do these, but it's catching you early.
Yeah,
13 doctors before they got.
yeah. Right, Jason.
Can I make a point? So I have shoulder impingement too. Part of it's anatomic too, the way your shoulder is built, and certain motions make it worse. When I serve in tennis overhand, I'll get severe pain. If I keep my arm to the side or not play tennis, I don't get that impingement. And what Glenn was talking about, the arachidonic cascade, about the swelling there, imagine if you have swelling of that bursa there, or the tendon,
This is the bursa.
the bursa right there. The more it swells, the more it gets pressed on. The more it gets pressed on, less blood flow. The more less blood flow, the more injury and more swelling, and it cascades itself. So that's why Glenn is saying take stuff early to prevent the swelling, which then leads to compromise of blood flow and worsened inflammation.
If you take it early, it keeps coming back, you're doing something wrong. Mechanically, something's going wrong. This is where you now need help. This is where you see the doctors.
And also the other exercise that was told for me to be helpful for impingement are retracting the shoulders, getting the rhomboids activated, because this frees up that
Yes, it
space,
frees
that
up. As we
subacromial
age,
space.
how many of us, our shoulders begin to round forward, right? You need to keep them back, and I notice in my shoulders, they're doing that thing.
Also stretching. Stretching helps me.
Stretching will provide you a good range of motion, and as long as you're moving pain-free through that range of motion, it works. But stretching doesn't work for everybody. Sometimes we want the opposite. We need some tightening, particularly as we get older, because there's a lot of loosening that's been going on as we get older.
Glenn, when you do these exercises, can we train, can we still play?
Yeah.
As long as you're doing the exercise, then go on to the court to play?
Yep, you can do
So
that.
you can play through the injury?
Well, unless playing is causing you pain. Unless weightlifting is causing you pain, then you shouldn't be doing it. Stop doing it. Pain's a good thing. There's a fourth exercise, called the oil can exercise. You bring the weights out to about 45 degrees, you internally rotate, and then bring them back. So the 2 middle exercises in here, the 2 that I said you should do, and they'll be in your handout. It'll be on. send you the handout, the page will look like this. It's this exercise and this exercise.
Look at me an email.
Okay, 2 in the middle. And if I were still playing tennis, which I haven't been, I would be doing those 2 exercises at least once a week. Once a week we'll maintain, twice a week to get stronger.
Can you do it 2 many times?
Can you do it?
I mean, what if you do it every day? Would that be better or worse?
Probably worse.
Okay.
You know, and particularly as we get older, we need more rest and recovery the older we get.
Okay.
We don't have the blood supply that we did when we were younger.
Okay.
All right. Knees are fairly simple to understand. How many of you have some knee issues now? A lot of hands should be going up. Yeah. So, what we now know is that around a 60-degree bend at the knee, we have normal compressive force working on the knee joint. And mechanically in this posture, the knee joint is strong, really strong. As long as your upper quad and your hamstring and your calves and your frontal compartment, these are the muscle groups that keep the strength, keep the knee positioned where it needs to be. As long as they're strong, you'll be strong and no issues there. But if we bend past a 60-degree angle here, shear force now becomes introduced in the joint. We used to say it was at the 90-degree angle. Now we're saying it's at the 60-degree angle. You begin to introduce a shear force, which means I've got this happening at, this would be my lower leg, and this would be my femur up here. It wants to either go forward or on an extreme backward in here, and the ACL ligament is not strong to handle that for 40 or 50 years. Particularly if I am a power lifter or a weightlifter where I do that full squat down there. It can cause havoc on your ACL and PCL ligaments. The ACL and PCL are the 2 in the middle. They do form the cross. Cruciate means cross. And their function is to stop forward and backward movement of the knee and to limit the amount of rotation your knee is capable of going through. So as they get weaker, as we get older because we've over-abused them, whether it's work-related or chore-related or hobby-related, it will be a problem for this joint when you get older. How many have knee replacements at younger and younger ages? It's happening out there. The other part of that umbrella is we've got 5 million people that are over 100 years of age in the US alone. 5 million over 100 years of age. So we're also lasting longer out there. So it's up to us. Oh, I've heard this several times in the last half a year. The stronger your leg muscles are, the longer you live. A correlation to longevity is leg strength. A strong correlation. Interesting. What do ligaments do? What do they attach to? Bone to bone. They hold your bones together. Tendons help them move. The muscle contracts and the tendon helps with that motion. Tendons are more like rubber bands. Ligaments have some give, but not a lot of give to them, which is why they've got even poor blood supply than the tendon has. Glucosamine is one of 8 essential sugars. It's required for some cartilage growth to occur. Studies have shown, some studies have demonstrated yes effect, some have shown no effect. The majority says some effect. And again, I think that's going to be your chemistry. My wife, it turns out she's got very sloppy joints, and she's got problems, so she's been taking glucosamine for over close to 40 years now. Her mom had 2 hip replacements and 2 knee replacements. Her sisters had the same. So it seems to be helping my wife better. She's only had 1 knee and 1 hip. And meniscus are the shock absorbers down here. And you notice that the shape of the upper leg bone, it's a typical dog bone shape. 2 round knobs up there. They sit in your right and left meniscus. They sit in there. If your ACL and PCL becomes too weak, it will allow the joint to rotate more than it should. And that's commonly when we get the tear of the meniscus. It over-rotated. I got hit, I went this way, and my leg went, my foot was planted, and I get a meniscus tear. What color is the meniscus colored? What color is the meniscus?
Titanium.
It's blue, right? You were right on. Is it painted red? It's got poor blood supply. And you can see the normal cartilage up here, and this meniscus is slightly different than cartilages, but they still both have poor blood supply. I want you to notice that the kneecap is sitting in a groove. And as long as your thigh muscles are strong and tight, that kneecap will stay in its groove. If it's not as tight as it should be, the kneecap will get sloppy, and you'll get some bone rubbing because you're not staying in the groove, and you'll get eventually what's called chondromalacia, a lot of bony spurs growing on the bottom of it. So if you feel your kneecap and it glides and there's nothing going on, you don't feel anything, you've got a pretty good kneecap. But if you're feeling crunchy, crunchy, crunchy going on in there, you've got some problems with that kneecap. And the kneecap can create some issues for you, particularly taking 1 step up, a high step up, or 2 steps up rather, or a step down. Stepping down hurts your knee, stepping up hurts the knee. That's a good indication that that kneecap is not staying in its groove as you're moving out there. And you can tighten that up with a simple exercise.
Real quick question, maybe for the doctor too. Does the, how do you pronounce that, glucosamine?
Glucosamine?
Glucosamine 1200, does that harm the kidney?
Not to my
I would
knowledge.
guess no, because it's a
Not to
sugar.
my knowledge.
It's one of the 8 essential sugars your body requires.
No.
No.
Okay. And it goes all over through the body, not just the knee?
Yeah, it's produced.
I mean, it
Yeah,
helps
it's-
other
yeah.
body. Okay,
Yeah,
thanks,
other body
sorry.
parts. Yeah. And the reason I say this is most medicines that you buy, you'll see 2,400, 3,000 doses like that. The 3,000 is a huge horse pill. The 1,500 is a huge horse pill. I recommend buy the 1,500, buy the 750, one in the morning, one at night. Here's what you do with glucosamine for any joint. Yeah, you take it for 8 weeks. Don't stop at week 7. Give it the full 8 weeks. It usually takes about 8 weeks before you notice anything. And if you notice it, it should be a significantly different response in your knee to make it work. And it has been in my wife, and so that's why she's paying for it for 40 years. Your body can only reabsorb 1,200 to 1,500 milligrams in a 24-hour period. So the rest of it is being peed down the toilet. So just take 12 to 1,500 milligrams. It comes with chondroitin. Most of my med docs that do, friends that do the research say the chondroitin doesn't have a value to it. Doesn't have a value at all. So you can buy glucosamine just with glucosamine. It came from the veterinary side of things. And it worked for dogs and horses. And it does work. They show the studies working well in horses and dogs and those kind all right. We're doing good here. Now, the back is extremely complicated, and yet, understanding the mechanics about what causes the issues is simple. So, anybody have an ongoing chronic back? Okay, quite a few. And raise your hand for those of you where it's disc related. Okay, 1, 2, 3, 4. And do you have a diagnosis?
Pickleball.
Pickleball. This is
If I don't
diagnosis.
play, it doesn't hurt.
Pickleball. Other than disc, what's it?
Facet joint?
Oh, facet joint, okay. So you got facet syndrome,
Yes.
right? Is there degenerative disc happening there?
Not yet.
Not yet, okay. Was it a car accident, was it a fall?
Just overuse.
Okay, from?
Golf, ball, hit work.
Okay. No spondylolisthesis, no moving forward of the joint or anything like that? Okay. So his joints, you have a joint on the right and left and on the back? Right here. That joint is called the facet joint, F-A-C-E-T. It is like every joint in your body, there's cartilage covering both the upper and the lower. In your low back, these sit side by side to prevent rotation from occurring. Does that make sense? I've got these mechanical structures to prevent my low back from moving back there. Because we need strength, we need tightness in order for this back to do what it's designed to do. But if I forward bend and I do this, what's happening to the joint?
It's killing you.
It's going smaller.
That's your comment. That was the joint itself, Bobby. What's happening to the joint? What's happening to the bones? They're spreading apart. Not opening up the movement that occurs in the joint and making my back less safe, less strong. Here is strength. Here is weakness.
That explains why my back hurts. My pickleball.
Okay?
And some people have it, some people have it this way, and some people have it this way.
She had what?
Some people have more back problems this way, the disc, and some people have it this way.
Not following that thought.
Yeah, that's the way the doctor explained to me, most people have it this way, and with me, I'm this way.
Maybe we talk about lordosis and
The shape of the spine? Yeah, kyphosis and lordosis. Kyphosis is the extreme head forward and up. Is it in your neck? I didn't even think that.
Facet, it was 3 and 4. And there was a.
On your elbow, at your elbow?
Yeah.
Okay, got it.
there's another important point about that. Under the facet is where the nerve roots from the spine come out. So you can have inflammation of the facet itself, the cartilage and the ligaments there, of the facet ligaments. But you can also have impingement on the nerve that comes out, giving you a numb leg, giving you sciatica.
Yeah. We'll talk about that.
Yeah.
So we got a joint on the right and on the left, like every joint cartilage there. And we've got a lot of ligaments holding this structure together to prevent that from really going astray and just getting sloppy and so forth. We have a vertebrae. This is like an egg shell. The outside is hard, but the inside is trabecular bone, soft bone. Because in this soft bone is where we manufacture the fluid that feeds the disc, and that happens when we sleep. And it takes a good 7 hours of normal sleep in order to feed a disc well. Discs begin to break down or lose its ability to do its job in men beginning at the age of 10 and in women age 17. It has no blood supply or very minute blood supply going to a vertebrae, to a bone, or the body of the bone. In between the bone are discs. The dark gray that you see here are the discs. And the disc is nothing more than a shock absorber and a spacer. The height of the hole on the side is driven by the size of your disc. So as we get older and as the age does degenerate, we lose the size of that hole on the side. The size of that hole is driven by the disc, but it's just two horseshoes. It's not a solid hole opening in the bone, like where your spinal cord sits. The spinal cord sits in a hole referred to as the central hole, the central foramen. And the hole opening in your body is called the foramen. We got 200 foramen in your body. But this hole opening can get smaller as well. How in the heck does that bone opening get smaller? What will cause that?
You're talking about in the central.
Yeah, where the central spinal cord sits. How can that get smaller?
The nerve gets bigger.
Because of the inflammation response, I've got that inflammation irritating the bone in there, and when bone becomes irritated, the body sends calcium to harden it. We call it a spur, or we call it a arthritis, depending if it's a joint or not joint. I was diagnosed 23 years ago with bony growth impinging 30% on my spinal cord and my neck. So my doctor said, no basketball, no sports, no nothing. 8 years of doing nothing as a gym teacher. I said, no, I'm going back to it. And I've never had a problem since. I've had no pain since. And yet, I had an MRI done last year. I'm still 30% impinged on my spinal cord without dysfunction. So you'll see a lot of people like that. I saw a picture of a guy who had spondylolisthesis, grade 4. His vertebrae is sitting out there in no man's land. It's not sitting on anything. It'll slide down. When he goes to sit back down, it kind of slides into a type 3 spondylolisthesis. But he had no symptom. How in the heck did that happen? Because the spinal cord goes, boom, boom, boom. How does that happen?
How does it happen?
Without a symptom. I don't know. It's a miracle.
Okay.
It's a miracle. Okay. And this whole opening is called a foramen. Central foramen here, lateral foramen is what the docs will often use for terminology. My central and my lateral. So in understanding ache and pain in your back and most of the common things that occur, if you were in a significant fall or car accident and you had significant trauma at a neck or back area, you're going to get early degenerative disc there. The disc was traumatized and the feeding mechanism did not go as planned. You will get degenerative disc there. Therefore, you need to optimize what you're feeding and exercising. You need to maximize your strength for the support of the muscle and the ligaments and the tendons that are holding the structure together. And you need to eat well to make sure that you're feeding all this stuff in the right way. A lot of alcohol would be poor. Beer increases the risk of degenerative disc disease. Hard liquor doesn't.
Really?
Prescription for that?
What about wine?
Some are.
Yeah.
What about wine?
Wine does not.
Unless you're Irish, then not.
Wine does not either. So, I've got 4 mechanical parts. When I bend backward, are my holes getting bigger or smaller? They're getting smaller. As they get smaller, what's happening to the 2 joints? They're compressing. There's more and more pressure on them. So for you working at Car Midas Muffler in your retirement, it doesn't work. It would irritate the heck out of the joint that's already irritated. So the big question is, why is it always inflamed? Is it always inflamed? Or it comes and goes?
Sudden onset.
I said?
Sudden onset, just can't.
Okay. But the doctor just labeled it as,
MRI, and then they saw there was a cyst on the facet disc
okay,
impinging on the nerve.
okay. All right. So is the cyst gone?
They injected it, and it also sucked out the fluid of the cyst.
In the,
I got to hear the description of the fluid.
it took out of the cyst, right?
Excise the fluid. out of
Yeah,
the cyst.
out of the cyst, you're saying, right. I didn't wear my hearing aids.
Sorry. And then I guess they used some type of steroid in there.
Yeah, they'll do that to get rid of the inflammation. And has it stayed away then?
Could last 3 months, or it could last forever. It's been 3 months.
So it's relatively new?
Yeah.
Okay. I'm gonna suggest the cause of the irritation is gone. It should not come back. And if it does, cysts do return, right? Relatively simple issue, complicated with the cyst, but easy to resolve eventually. Just stick with it. When I forward bend and I got this curve here, and I lose the curve, the opposite is occurring. The foramen are opening, the facets are spreading apart. My muscles are elongating. Is that a good thing or a bad thing? That would be a bad thing, because what the muscles give me strength. And it tells me I'm going away from strength. The more round I get, I'm losing strength. The purpose of our muscles are to position our body, to posture our body. So my muscles are designed, when I stand, I got these 3 curves. Why? Why do I have 3 curves? I got an inward curve in my neck, an outward curve in my back, another inward curve. It's a spring. It's designed to absorb energy when we run and jump. And it does it very well. But if I were to run and jump like this, how much am I absorbing? And where is the pressure impacting my body? 2 areas. The bottom 2 discs in my neck and the bottom 2 discs, the last 2 discs in my low back. I am putting the most force on these 2. So where are the 2 most common disc-related injuries? C5, C6, C6, C7, L4, L5, L5, S1. Those are the common discs. Over 82% of disc surgeries are done on these 4 discs. The 2 here feed the arms. The spinal nerves at this level, at these 2 levels, feed your arms. So if you're getting bilateral symptom and it's down your arms, we know that you got a problem at this level right here. So it's easy to understand. Mechanically, what were you doing when you had your onset of pain? Now, car accidents, falls, those are difficult things, but the same thing's going on. If we did a videotape, I could tell you exactly what's going on inside, where the pressure would be, and this facet joint closed and this facet joint open, because there was some of this that came into play, side bend, right? So depending on the position that you're in, that presents your onset of symptom is fairly easy to understand. It's like going to a car mechanic. Your car is mechanic, so is your back. It mechanically operates, and it's easy to understand those symptoms, those systems as well. What we want to do is always maintain this curve. Whenever we forward bend, we want to maintain those 3 curves. Can you picture your grandkids, 3 years of age, picking anything up? They are perfect lifters. They cannot do it this way because the torso is too disproportionately long at this point in time, and the head's too disproportionately heavy at this time. They would fall flat on their face, which is why we're not born with 3 curves. They take about 4 to 5 years to develop. So we're born in a way that will develop the 3 curves of the spine. Now, do some people have some anomalies in how that spine develops? Yeah, they do. Kyphosis and scoliosis and all kinds of other things. But those are outside the norm. If you do have some scoliosis, it means that if you always do your exercises, you will not have symptom. And it's true for those who do it. It's also true for those who don't do it, because they end up with problems. They will have problems if they're not doing their exercises to keep one side open, open up the one side that's closed and close the one side that's open too far. You just got to do the exercises.
Then you also have to consider that we evolved from quadrupeds, being on four limbs, like a dog, like an ape. And now as we've become bipeds and standing up, now our spine changes, like you said, over time, because we're upright and not bending over.
I have a quick question. What happens if the cervical curve is more straight than normal?
That loss of cervical lordosis puts a little bit more pressure at L4, L5, L5, C5, C6, C6, C7. I've lost the mini spring that's here, and so I have lost it, probably from my injury from over 30 years ago. I have lost it now. So when my head goes forward, it doesn't go forward with the chin up. It goes forward this way. It just stays there. It's not too much of a problem, other than this is 12 to 14 pounds, depending on the size of your head. And that bowling ball can put a lot of stress and cause some neck and headache issues if my ear is not over my shoulder. That's what we're looking for in terms of head posture, ear over shoulder. And in work environments, I go in, secretarial, and I got neck issues, took a piece of tape, put it in their hair, put it on their shirt, and I come back an hour later and said, how did I feel? She said, I was constantly pulling my hair. My head was constantly going forward. Well, that's a sign that's causing you some stuff. Long term, it will become real problematic for you if you don't keep that ear over shoulder.
Thank you.
Okay? So in the design of the disc, the front wall is twice the size as the back wall of the disc. And that front wall is thick because it can handle, it's designed to handle, as long as you maintain this curve, it's designed to handle upwards of 2,000 PSI, pounds per square inch. That wall has that capability. A fall greater than 6 feet can generate more than 10,000 PSI, which is why a fall can cause bulges and herniations and ruptured discs. The back wall is twice the size, I'm twice as thin as the front wall is. There are about 6 to 8 layers, depending on what level you're talking about in terms of the walls. They're fibrous tissue, very, very strong. It takes an awful lot for it to bulge, herniate, and rupture. In my years of doing this, I've only come across 2 people I did back training at 4 area hospitals for post-operative patients. I had 2 that ruptured toward the front wall, only 2 in all my years. One fell off of a roof and landed over a railing in this position. And the other guy got hit. Got hit from the rear. Down here, it was a tackle and got hit this way. And he ruptured out toward the thick front wall. All my other cases were just the opposite of that. So in that design, the design says it's designed to keep that jelly going forward. Because of the spring, there's an angle that each vertebrae are at. And in my low back and at the 2 of the neck, that transition really has an exaggerated angle there. If I go in the opposite way, the jelly is now going to be pushed toward the thin back wall, and that thin back wall will bulge with a 10-pound lift at ground level if you weigh 200 pounds. You're generating 880 PSI with a 10-pound lift at that level. So how heavy is too heavy in terms of preventing back problems? How heavy is too heavy? What do they use in industry? What number do they use?
40 pounds.
Say it again?
40?
Yeah. It used to be 50, and that's because there's a formula out there. It's called the NIOSH lift formula. There's 6 variables in the formula. You just measure them. It's fairly easy to do. On your computer, you can do NIOSH lift formula, NIOSH, National Institute of Occupational Safety and Health. This formula was developed at the University of Michigan's Center for Ergonomics, and it comes up with, no matter what position you're in, it comes up with a number. You can lift up to this amount here at this level, at this posture, based on these parameters, your height and so forth, your height and weight. And so we know at ground it's around 17 pounds, even though it generates more than 800 PSI. Because as long as I maintain my 300, my inward curve rather, all that 800 pounds is going toward the thick front wall, not a problem.
More pressure on the small of your back than the back.
Yeah, it's a smaller back.
Yeah.
Right. That's where your 4 and 5 and S1 are, the small of your back.
Well, what about the muscle back here? These muscles rather than the back? What that
Yeah,
straight is.
they spasm. And why would they spasm? Because they're tightening
Right.
to keep you in position of strength. I don't want you to move the way you've been moving because it hurts you. But the spasm becomes more problematic because it begins to hurt more and it begins to atrophy the muscle at about 2 days of spasming. So you need to get rid of spasming, which is why you go on the
Flexural.
yeah, flexural. Thank you.
But why?
Pain reducers, pain relievers, flexural. You take flexural and some people go really, where am I? On some of those drugs. I didn't, but it worked really well for me when I had my injury 30-some odd years ago. So, I want you to notice the spinal nerves. You have really thin structures coming off both the rear of the spinal cord and the front of the spinal cord. As they begin to approach the foramen, the hole over on the side, they all remerge. They're little tiny fibers out there. So if you get anything in this space like inflammation, they go, ow, it hurts pretty quickly. Pretty quickly. And if an anti-inflammatory takes it away immediately, we probably know that it's an inflammatory response hanging out because something's irritated at that level. That's a good indication for that. And if you take it early and it goes away and it stays away, you won't have to do that, but the next time it comes back, you need to break the cycle. A bulge says there's no damage to the disc at all. All of the walls, remember I said that there's 6 to 8 different wall fibers that make up your disc? They're all intact. A herniated disc says you've broken through some of those fibers of that wall. And notice the shape of the thin back wall. I have a corner inward indentation and another corner over here. So with even slight rotation, when I forward bend and I begin to lose the curve, I'm driving it into that corner. The left corner or the right corner. And that's right where the root nerves are. The root nerves are right in this corner. So if I'm bulging here, you can get central bulges and herniations and ruptures. Statistically, 10-15% of people may show up with those in a year. 80% likelihood that it's going to be in the right corner or left corner, which is why your back pain tends to be one-sided. If I'm just impinging a right root nerve, I'm only going to have right leg symptom or right body part symptom. Generally speaking, if the pain stays here, that's better than going down the leg. And the lower it goes, it generally means it's more of a problem than we would like you to have. So when it's hitting that big toe down there, and it's constant, and it's there for 8 months, mine was there for, I've lost track of it, 34 years, until my massage therapist, she's the best massage therapist I've ever had. Do you know Nels Madison, anybody? Ring a bell? He's the guy that ran from San Francisco to New York City Hall recently. He became the 3rd fastest guy to do it. Number 1 guy, 27 years of age, the other guy's 31. Nels was 42 when he did the run. Anyhow, his wife is our massage therapist. She
Down
is
here?
wonderful. Yeah.
What's her name?
He's Nels Matson, and she goes by Denise Zolo. Zolo Matson. Zolo, Z-O-L-L-O. She's wonderful. She won't do you just to make you feel good. You have to have a problem for her to see you. My big toe hadn't been on the ground in years. In 3 months, she got my toe on the ground.
But you got back to the toe, not just the toe.
I had back to the toe.
Okay, because
No, mine was just the toe.
can't you have just the toe and have arthritis in the toe?
Yeah, but it's back related.
Okay,
Yeah,
all right.
I know that.
Okay,
I can follow the nerve root right down the leg
all right,
here, and I feel it in my toe.
got it.
And a rupture is when you've broken through the last wall. Now, what's a little bit unusual is the treatment that we do for you, most therapy or chiropractic, whichever you choose to do, for these 3 conditions are all